Today, I would like to talk to you about prevention in rheumatoid arthritis. So our team for the moment is composed with Professor Paul Emery, who is at the head of the team, working close with Dr. Mankia. And also there is myself, Laurence Duquenne, and Kate Herndon, and our dear colleague Jackie Nam as well. So the plan for today is to talk about patients who are at risk of developing rheumatoid arthritis, which is the area we are working on. I will first define what is rheumatoid, what are the factors that leads to the development of the condition, and also the markers that can help us to predict progression to rheumatoid. Rheumatoid arthritis will be referred throughout the presentation as RA. So, and I will say RA as it is quite easier to say. Then we will talk about the development of future studies that will involve drugs that are already used in RA, and maybe we could use them before the onset of the condition. And then we will talk about how could all of this be helpful for the NHS and the treatment and patient care. So first of all, rheumatoid arthritis in itself. So what is rheumatoid arthritis? It is a chronic immune-mediated inflammatory condition. It is the most common cause of chronic inflammatory joint disease. It can affect 1% of the population, but in some area it can reach 3% of the population. It commonly affects 30 to 50 individual patients to between 30 to 50 years old, but it can start at any age really, and it's more often women. They are 3 times more likely to be affected. There are some genetic predisposition. Some genes have been identified, but these genes there are multiple of them, and these are not extremely strong. It means that it's not because you have the gene, you can be tested for the gene, it's not because you have it that you will develop the condition. You are at risk of developing the condition, but it is not 100% sure. It is why in some families, like some large families, you have a few individuals who have the condition, but not all of them. Environment is very important, especially smoking and some inflammation of the mucosal tissues, but we'll discuss that later. So what is rheumatoid arthritis? It is a condition that affects joints on both sides, right and left, and also it is symmetrical. So very often it affects both hands, both wrists, both knees, and both feet. It is accompanied with swelling, pain, and stiffness. These are the 3 major symptoms. It can be accompanied with fatigue. As your immune system is firing up and always working, it can take some of your energy. There are some extra-articular manifestations, such as rheumatoid nodules that can be seen just under the skin, and some pulmonary fibrosis or nodules that can be found on chest X-rays or in CT scan. These are more, they are not always present, it's quite rare. The thing is, when patients are not taken care of, some chronic inflammation will settle in these joints, and this chronic inflammation will induce damages, and then damages progressively will lead to deformity and decreased range of motion, loss of mobility, and in the end, chronic pain. So throughout the presentation, I will talk about the disease continuum. What is it? So arthritis, as we were defining earlier, is usually made of swelling, pain, and stiffness. So here you can see the swelling. It is at that moment that patients come to clinic, and at that moment that we start treatment. You will see that in my speech, I will always talk about patients here, and here I will talk about individuals, because before this line, individuals do not have that swelling, so do not have the diagnosis of rheumatoid arthritis. We now understand that this phase, which we call, sorry, I thought I put some arrows there, which we call the preclinical phase, has can start many years before the onset of arthritis. And at the beginning, we find the risk factors, which are the genetic and the environment factors. Environment can be smoking, there can be viruses or bacteria, there can be some different influences that we are not all aware of right now, but for the moment, it's the one we know. And then progressively, the immune system will see itself some kind of disbalanced installing. And then so our white blood cells will start to develop autoantibodies. So the white blood cells are made are designed to make some antibodies that are very specific to the viruses or the bacteria that we encounter in our lives. But sometimes they misunderstand, or then they misreact, and they develop antibodies against oneself. We all have autoantibodies against ourselves, but then our immune system is there to recognize them and to suppress them. But it appears in some individual, they will evolve, and this autoimmunity will bubble up to, at some point, create some inflammation. In here is what we call subclinical inflammation. We get closer to the onset of the condition, but the inflammation cannot be seen on examination, but there could be some inflammation in the blood test, there could be some inflammation in the ultrasound scan. The most important to know is that along this continuum, some of the individuals who are at risk of developing rheumatoid arthritis will not evolve. So some people with the gene will not develop arthritis. Some people who are smokers will not develop arthritis, and even some people with this antibody, which is quite specific, will not develop arthritis. So how can we identify those who will, to try to maybe target them and work with them into preventing the condition? So what are the markers that can predict progression to RA? So early in the continuum, so in the yellow area, there are the genetic markers and the environment markers. So smoking, what we call periodontal disease, which is gum disease, and the microbiome. Microbiome is the balance of bacteria that we all have, for example, in our guts, in our lungs. In the guns, we have kilos of bacteria and there is a fine balance between them, and we live with them friendly and everything goes well. But then we have realized that in some patients with autoimmune condition and those at risk of developing the autoimmune condition, there is a disbalance in this gut microbiome, and there are more people with gum disease as well. And the antibodies. So in the context of rheumatoid arthritis, the CCP antibody is very specific to rheumatoid. And there is an older one, which is called the rheumatoid factor, which is less specific, but still very helpful, especially gathered together. Later in the continuum, when we get to the orange phase, is what we call the imminent progression. What can you see in imminent progression is you can see that in the blood test, there is an increase in inflammation markers. In the ultrasound scan or Emery scan, you can see some inflammation showing up. And also the patient will report some symptoms. Some won't feel as well as generally well as usual. Some will be more more fatigue, more tired, and some will express some pain. Even if there's no swelling, they could be painful, some pain and some stiffness as well. So in order to identify those, where our individuals at risk of developing RA are in our continuum, in our preclinical phase, we try to combine all the best predictors and try to categorize the risk of progression of each individual. At present, four models have already been developed, one in Amsterdam, It was quite a while ago, but it's still very efficient. There was one model, and they use 9 markers that are clinical demographics, such as smoking, age, what the patient reports, and also the antibodies in the blood test. And they have managed to predict progression at 1 year, and those who are at high risk, 43% of them would develop rheumatoid arthritis. At 3 years, 74%, and at 5 years, 81%, which is very high, but a very long time to follow the individuals. In here, in Leeds, we developed in 2015 some models as well, using as well clinical examination of the joints, antibodies in the blood, genetic tests, and ultrasound. And those identified at high risk of progression. In these patients, 72% will develop rheumatoid arthritis. Another model has been designed here, but using a immunology test that is not widely available within the UK or even largely on the continent or otherwise, which is very efficient with 63% chances of progression, but hard to use outside of Leeds. And then in Leiden, somewhere else in the Netherlands, they have developed another model using only clinical findings, so just no need for blood tests or anything. And in these patients, they found out they can identify 30% of those who will develop rheumatoid. This is an example of what we want to achieve. So this is what we call a survival curve. So for example, you see a patient for the first time at month 0. The first visit, you do some blood tests, ultrasound scan, clinical examination, and a few questionnaires to have a few information gathered together, and then you identify those patients. You tell this patient, okay, you are in the high risk group of developing rheumatoid arthritis, which means that like those who have been identified in the past, in 1 year, so in 12 months, you have almost 40% chance of progressing to rheumatoid arthritis. It is very important to know for us, but also for the patient. It's a lot to think about because 40% is very high, but there's still 60% chance not to develop the condition. And considering the treatment that are necessary to take in rheumatoid, it is interesting to know at what is our risk to develop the disease. And then the decrease quite fast, progression rates are quite fast at the beginning, and then it tends to slow down. So let's say 80% of these people will develop rheumatoid arthritis, but in 80 months, that's a very, very long time. So all of this has to be taken into consideration when we think about treatment. So we need to improve our models, our scores of our prediction as much as possible. So we need more markers. So here in Leeds, we have a periodontal program where our patients are seeing dentists, and we analyze their gums, and we try to identify who has gum disease or not. And we take samples as well to evaluate, to analyze also the microbiome and the balance between the bacteria. Our colleague, Dr. Rooney, is well involved in the gut. He's analyzing the stool samples of our very generous patients, or actually participants in our studies, and he does compare to healthy control and to people with rheumatoid arthritis as well, to see is there a shift in the microbiome balance or not. And we do analyze antibodies in these as well, in the sputum, that is in the sputum, so the sputum from the lungs. We also try to find novel biomarkers in the blood. We have a biobank which is quite with a lot of samples, and we can try novel biomarkers that did not exist in the past. So there is CCP3. So for the moment, we are for identifying patients with a CCP2, so second generation test, and there is a third generation that has happened, so we can compare the third to the second one. There are other antibodies that are very more analyzed by the lab, but not used in current practice. And there are also some different cohort as well that we can compare our patient to. For example, palindromic rheumatism. It is not patients who are at risk of rheumatoid arthritis per se, because they did have some inflammation and some swelling, but the swelling tends to settle down on its own. So they present flares of rheumatoid, but then it always settles on its own. So it's a kind of a different form of rheumatoid. Interferon signature is a cytokine. So like the proteins that serves the communication between white blood cells can be different in these patients. So we do go a bit further into the genetic studies to investigate. Personally, I work more on risk stratification. So because we really want to try to find a model or a score that would be easy to use in standard practice, but also powerful, so we can really identify those that are at high risk of progression. We share our data with EULAR task force. So EULAR is the European League Against Rheumatism. Secondary care means that we see patients here in Chapareton, individuals here in Chapareton Hospital, but also we do work with loads of GPs all around the United Kingdoms, and who have the ability to test a wider population. So they have less CCP positive patients, but they test more people. So we have loads of data. We have more than 8,000 data for them, and more than 13 years of data. We also record ultrasound scan and MRI scan for these patients, and soon we'll do some machine learning to really find statistically the best score and the best model to predict. Oops. So I know I took a long time for this first part, but I think the most important to understand here is how research has to focus on the identification of the high risk of developing rheumatoid, because if you take the patient too early in the disease continuum, they are less likely to, there are obviously less rates of progression, and they are less likely to be willing to participate in any kind of intervention studies, or because obviously the risk is much lower of developing in the near future, which is logical. So at present, we are working quite intensively in developing future studies that will involve drugs. Those drugs are those that are already used in rheumatoid arthritis. And I think lots of you know some of these drugs and have used some of these. And you know that they are not without consequences, and you know that loads of side effects have to be taken in consideration. So there's always risk versus benefits to think about. So why should we treat this patient, and also what is our aim and what are the challenges? So our aim, the aim is to overall, with every patient that we see arriving in clinic in the within the clinical phase, is to make an early diagnosis as possible, and also to treat as early as possible. Why? Because it has been proven that people that are treated in the 3 first months of diagnosis and put in remission as fast as possible will have better outcomes in the long term. 3 months it's what they have proven. It could be 6 months, but that has not been analyzed. But they know that if they are treating the first 3 months compared to the first year, they will have better outcomes. And they call that the window of opportunity. The window, it is in this window that if we treat the patient, they will have the best outcome in the long term. So our aim is to see, could we extend this window of opportunity? You know, this moment where inflammation is building up, and you can see it in the bloods, you can see it in the ultrasound scan. almost quite often, but still there is no swelling. Could we start treatment at that moment? Should we start treatment at that moment? What is the percentage of these patients that are at imminent risk of progression? And so would they benefit the most from a preventive treatment? When is the best moment to offer treatment to a patient? What are the challenges? The challenges are that not all at-risk individuals will develop RA. So if someone is here, has been identified here, like for example, with a positive genetic test, the risk of developing rheumatoid is there, but not all of these patients will develop rheumatoid. And then even if they evolve through the continuum, it's not sure that they will ever develop rheumatoid arthritis. That is why it is very important to identify them and to stratify them. Unfortunately, even though there are some models that have been developed, we have no international consensus. That is why we are working with the European League for the moment. Yes. Another issue is that markers can fluctuate. Some people will show some sign of inflammation in the joints and in the bloods, but it can settle down at some point. And we might discuss this later on with the COVID-19 infection. But how can we be sure that this inflammation that is building up cannot just settle down through the normal checkpoint inhibitors from checkpoint from our own immune system that recognize that some autoimmunity, something wrong is going there and just settle down. And then also there's the patient, but also actually the doctor's point of view. You want to balance risk versus benefits. Do I want to take a medication with potential side effects, knowing that I'm not sure to develop the disease one day? And also, if you have been diagnosed with rheumatoid, you know the symptoms, you know the intensity of the pain and how horrible it can be. But if you haven't lived it, it's hard to imagine and to think, oh, I could start a treatment right away. So there are some intervention trials that have been done and some that are still ongoing. So the first one quite a while ago was to give steroids to patients. It was 2 injections of steroids. And they have seen that 6 months and 1 year later, there was a similar rate and time of progression. So steroids did not have any effect on them, on the progression. Rituximab is a very specific medication. It is a drip that is that is targeting the cells that are producing antibodies. It is very efficient in rheumatoid arthritis, and usually it's given 2 infusions every 6 months, to every 1 year. And here they would give only 1 infusion to these patients and just follow them afterwards. And they were saying that they couldn't prevent rheumatoid for coming to start, but they could delay its development. That was the start. Another medication was trialed as well, which is called abatacept. It is a targeted medication against the mediators in between white blood cells. It is also very efficient in rheumatoid arthritis, and we still don't have the results. We're still waiting for them. And whilst these patients were just individuals with a positive antibody, these ones had a high level of antibody. This one, we are waiting for the results, which might be very interesting. You've all heard of the hydroxychloroquine because of COVID, but actually it is a medication that is used quite commonly in rheumatoid arthritis, in lupus, another autoimmune condition. The hydroxychloroquine has been given to a patient with a high level of antibodies. It's the CCP3, actually. This is in the USA. They use the CCP3 already. And we will see. We are still waiting for the results. Another one that is interested, not for its result, but why it didn't work, is that in the Netherlands, they tried to give some statins to individuals at high risk of progression with high levels of antibody. And they tried to give them atorvastatin. Statin is a medication against cholesterol, so it could feel a bit counterproductive, but it is a medication that has been used by many people all around the world. And also, although it is decreasing cholesterol, it is known also to decrease the level of inflammation in some arteries. So the rationale was to consider this medication in pre-RA, so what we call pre-RA, it's the at risk of RA cohorts. Unfortunately, the trial was interrupted because they couldn't find individuals who agreed to take the medication, which is interesting. And also some of those who agreed to participate were not taking the medication. They had very low compliance within the study. So what is happening here in Leeds? We have two intervention trials one who has started, which is on the gum. So we select a patient with high antibodies level who have gum disease, and we offer them gum treatment. So actually the gum treatment you would have with your dentist. So the intervention is not very intrusive, and it's still ongoing, so I have no results for this. It has very recently started, I think 1 or 2 months ago. And there's this one that is hopefully about to start in the following month, who used one of the models that have been developed here in Leeds to select people with high risk of progressing to RA, which are high antibody levels, some specific joints tender on examination, and an early morning stiffness of more than 30 minutes. On this, I haven't talked so much about the stiffness. Stiffness during rheumatoid is when there is active inflammation. The stiffness in the joint is more intense when the joint is cold, so when you haven't been using it for a while, so it's especially in the morning. So the threshold of 30 minutes, and sometimes some other scores use the threshold of 1 hour, is quite specific of an active condition. Obviously, there are lots of other markers for the morning stiffness. And the EXIST study will use a targeted medication, which is not a drip or an injection, it is some tablets, and it is quite a recent treatment that has been approved by the FDA. I think it's been only there for two years. And we hope to, and this will be compared to placebo. There it is. And how could this be helpful for the NHS? How can we translate this to treatment and patient care? So what is the impact on the NHS that all of these studies could lead to? So first of all, I believe in the visit, so the rate of the visit, when do we see patients? So if we manage to stratify patients, then we can say to patients at low risk that are at the beginning of the continuum, say, we'll see you once a year, and we'll just keep on following you. And then those at high risk, or what we call imminent risk of progression, maybe we would tell them to come once a month or once every 3 months, maybe, depending on the patient and depending on the score. Who to see, so either they are followed in secondary care, but if we do some powerful models that can be used either at when we see them for the first time, and maybe we can continue to use them at every visit. Maybe a visit with the GP would be sufficient. If we just need a blood test and a clinical examination, they wouldn't have to come to the hospital. That would be good too, and good for the NHS. And what tests to do? Is it just the blood tests that are the best? Do we need the ultrasound scan every time they come, or depending on the risk status? That is a good question to ask. So if we decide to wider this window of opportunity, and we decide to treat patients earlier, when do we do that? So when do we put the line in between in this long hour of preclinical phase? Do we only with those who we identify to progress in the next 1 year, in the next 2 years? So we're not sure. Then yes, and who to treat as well. So what risk? Do we treat only the high risk? Do we start treatment with the moderate risk as well? What treatment? So we have so many treatments for rheumatoid. Do we try to strike strong and go with the targeted therapies, which are very often injections or infusions, or do we try with the tablets, knowing that there are lots of potential side effects in each and every of them, and for how long? Because if you give rheumatoid arthritis treatment for someone who is at risk and they don't develop the condition, which is perfect, brilliant, and your patient has been on medication for 2 years, then what do? Do you try to stop it? Do you keep on continuing? It's a lot of questions, and each one of them needs to be addressed by a study, by teams, and more we need international consensus and everybody to work together to define the pathways. And the pathways is what they do in the NHS, is like define if it's primary care, secondary care, which test, how many often we see people. And that is the impact that you can have on the NHS. Voilà, thank you very much.